Okay, welcome everyone. I think we're about ready to get started. So good afternoon or good morning, depending on where you are. And thank you everyone for joining us for a special edition of our seminar series. This one brought to you jointly by KC Canada and the Spore Evidence Alliance. So today we're going to have two presenters. We have Ms. Lisa Nisley and Dr. Amanda Wurz. So I just want to remind everyone, since our procedure will be a little bit different for this session, so our first presenter will be Dr. Wurz, and she's going to present for about 20 minutes, and then we'll have 10 minutes for Q&A with her, and then we're going to switch over, and Lisa Nisley is going to present for 20 minutes, and then we'll do about 10 minutes of Q&A with her. So if you have a question that you would like to ask, please send it via the chat box. If you send it to everyone, then everyone will be able to see your question, and that can be helpful. If you prefer, you can also send it just to KT Moderator, and in either case, I will read it out to the presenter so they can answer. So we're going to start with Dr. Amanda Wurz. Now, Dr. Wurz's research is focused on developing and testing physical activity interventions to promote health and quality of life for children, adolescents, and adults diagnosed with cancer. She has experience in a variety of research designs, methods, statistical techniques, and substantive areas relevant to her field. As well, she has experience developing community-based physical activity programs, collaborating on large multi-site trials, and synthesizing evidence. In her research, she balances rigor with pragmatic considerations in an effort to get more individuals diagnosed with cancer active. In her current position as a postdoctoral fellow, she is developing, implementing, and evaluating in-hospital physical activity for children and adolescents undergoing treatment for cancer. Both presenters today are recipients of the Spore Evidence Alliance 2019 Seed Grant, where the theme was Advancing the Science of Patient Engagement in Research. So I'd like to pass it over now to Dr. Wurz.
Hi, everyone. Megan, thank you for that introduction. As mentioned and as is indicated on my slide here, I'll be speaking to you today about an implementation project using an integrated knowledge translation approach that's part of my postdoctoral program of research. So specifically, we're seeking to develop in-hospital physical activity opportunities for children and adolescents during treatment for cancer through partnering with key stakeholders. So when you walk away from your computer, and I'm sure another video call this week, my hope is that you will have a greater understanding of the benefits of in-hospital physical activity, a better idea of the scope of implementation of in-hospital physical activity, both locally but also internationally, and that you'll have learned about some of the efforts we're taking to implement in-hospital physical activity in Alberta, where I currently am. So to get started, pediatric cancer refers to cancer that's diagnosed in a child or adolescent, typically before the age of 19 years. And this group is considered to be a small and distinct population because the diagnosis of cancer in this age range is quite rare, and because this group has a very unique cancer experience. It's a leading cause of disease and death, and as you might be able to imagine, being diagnosed with a chronic disease, undergoing intense and long-lasting treatment regimens, and confronting mortality during a time when you're learning how to engage with the world, define yourself, establish your relationship, can have huge negative implications. So because of these things, we know that children and adolescents experience a high symptom burden during and after treatment that includes things like decreased physical function and fitness, metabolic syndromes, osteoporosis, cardiopulmonary dysfunction, fatigue and anxiety, as well as lowered self-esteem and quality of life. So researchers have concerned themselves with identifying interventions or strategies to enhance health and quality of life, or to metaphorically pull back or counteract this burden. And one strategy that has been found to address or improve many of the negative effects of cancer and its treatment is physical activity. So we and others have found that physical activity can positively impact outcomes across physical, psychological, social, and even cognitive domains of functioning. However, at this point, I do think it's important to acknowledge that the field of physical activity and pediatric cancer is still relatively young. And like any other young field, there are still some gaps in the evidence that we have. So much of what we know, for example, from descriptive studies comes from samples comprised of long-term cancer survivors, so individuals off treatment for years or decades. So we still need more research from diagnosis onward. As another example, many of our experimental studies suffer from being underpowered due to the small population we're working with, as pediatric cancer comprises less than 5% of all new diagnoses each year. So we still need larger multi-site efforts in order to build a bigger evidence base. Nevertheless, we still have over 20 reviews and 70 experimental articles on this topic showing the benefits of physical activity. We have published, or we have a forthcoming guideline and recommendation statements that are under review for publication for physical activity in pediatric cancer that were developed by a team of 120 international experts. And we also can look to the broader physical activity literature and the positive impact that we know physical activity can have. So when we look at all of this together, the expert evidence generally agrees that children and adolescents with cancer should be moving more, particularly during treatment. So we know that physical activity during treatment can mitigate symptoms and side effects like fatigue and nausea, protect bone mineral density and muscle strength. There's early evidence to show that physical activity might even be able to impact immune function and recovery. And it can also enhance psychological outcomes, so improving feelings of control, self-esteem, and social support. Because of these benefits, in-hospital physical activity is a part of care in other countries. So we did an international environmental scan last year, and we identified 13 in-hospital physical activity. Oops. I was hoping to play a video, but I might not be able to. I'll give it one more shot. My technology. Oh, there we go. This is from a team in Finland, and they've actually created a huge campaign in their country to make physical activity part of care for all children. And so in the international environmental scan we conducted, we identified 13 in-hospital physical activity programs in countries including Finland, Italy, Germany, Spain, and France. Some of our international groups have also developed documents for select stakeholders, like manuals for healthcare providers and children and adolescents diagnosed with cancer, and their families that summarize and distill evidence for the safety and benefits of physical activity. These manuals also offer practical guidance for being active or discussing physical activity. And so two good examples of the manuals that we currently have are the Guide for Being Active During Cancer Treatment, and I don't know if you can see my mouse, but it's the one on the far left of your screen there, and that was prepared by a group in Australia. Another great example is the Pediatric Oncology Exercise Manual, or the POEM, which was prepared by a team of international experts, and it was led by researchers in the lab where I'm currently doing my postdoctoral fellowship at the University of Calgary. As well, here in Calgary, we do have the PEER program, or the Pediatric Cancer Survivors Engaging in Exercise for Recovery program, which is offered in the community to children and adolescents affected by cancer. So really, with regards to big picture scope of implementation, we are certainly seeing a lot of efforts and quite impressive efforts to move evidence to practice, and we have some really great examples to draw on. However, in Canada, there's still a large knowledge to practice gap, as in-hospital physical activity just still isn't being offered. So this means most children and adolescents diagnosed with cancer aren't receiving the benefits that we now know physical activity can offer them. So that brings me to our implementation efforts and the steps we're taking here in Alberta to start closing this knowledge to practice gap. So as part of my postdoctoral research, I'm seeking to develop and then implement and evaluate in-hospital physical activity opportunities for children and adolescents during treatment. And though other smaller and bigger projects are being undertaken alongside this work, today my focus is going to be on the important and foundational work of first developing appropriate in-hospital physical activity opportunities that is funded by the SPORE Evidence Alliance. So to do this, we're using an integrated knowledge translation approach within the Knowledge to Action framework. And I do recognize who I'm speaking to today, but I think it's important to highlight that by working alongside stakeholders, fostering partnerships with these individuals, and engaging in a collaborative process to develop in-hospital physical activity opportunities will enhance the likelihood that the opportunities we create will actually fit and work within our existing infrastructure, and will enhance the application and relevance of our work, thereby facilitating its use and uptake, and ensuring our stakeholders feel a sense of ownership over the results. So when I say stakeholders today, I'm referring to three different groups. So first, international experts who have successfully developed, implemented, and evaluated their own in-hospital physical activity. Second, local healthcare providers and staff at the Alberta Children's Hospital and the Stollery Children's Hospital. And children and adolescents diagnosed with cancer and their caregivers in Alberta. So as a first step, we have spoken to international experts, and this is because we felt it was important for us to learn from those who have experienced success and who have done what we want to do. So from our own network and relevant literature, we connected with 11 experts from 6 countries to learn about the barriers and facilitators they encountered when developing and implementing their own in-hospital physical activity. We conducted qualitative interviews and used principles of qualitative description and thematic analysis to analyze our data, and we used a hybrid inductive-deductive approach throughout. So the deductive approach was informed by the Consolidated Framework for Implementation Research, or CFIR, and the Theoretical Domains Framework, or the TDS. And these frameworks informed our interview guide questions and also the way in which we coded our data. And then the inductive approach included open-ended prompts and probes, and while we were analyzing and coding our data, it really enabled participants' voices to be featured and allowed for themes and ideas outside of the scope of these frameworks to emerge. So what we found from these interviews was, as expected, that multiple factors impact development and implementation. And we categorized these factors into 5 broad and overlapping themes, which I've listed on this slide here, and I'll go into more detail on the slides to follow. However, I should say at this point that each of these identified factors served as a barrier or something that impeded or slowed development and implementation efforts. And our experts shared how they overcame, and in some cases were even able to leverage each in moving forward with in-hospital physical activity at their site. So on this slide and the slides to follow, I have put some representative quotes for each theme. So with regards to relationships with other professionals, experts recounted the difficulty they experienced identifying champions, developing in-hospital physical activity, and becoming integrated within multidisciplinary teams at their hospital. So to overcome this, experts spoke about the importance of sharing information about in-hospital physical activity and its benefits, respecting the schedules of the multidisciplinary team members with whom they work, and above all, really the necessity of fostering collaboration and the time and effort and clear and constant communication that goes into managing these relationships came through. And I'll just give you a moment to read what the experts said about this theme. In terms of available resources, the experts described how they navigated the limited resources and in many cases worked to spur changes over time. However, when reflecting back to when they started, they described developing their in-hospital physical activity with the existing space and equipment constraints in mind. Only once they implemented it and started experiencing success did they start leveraging resources, attending hospital board meetings, lobbying, and working with and allowing parent and caregiver groups to help them secure continued funding. When describing institutional values and norms, experts explained that when physical activity was not the norm, it was more difficult to implement, and some participants identified a negative culture around physical activity, whereas some didn't actually encounter this as a barrier. But regardless of whether they kind of came up against these values and norms in a negative way, or whether they didn't notice too much negativity at the outset, all of our experts noted that the values and culture at their institutions has been changing in recent years. And this is in large part due to identifying champions, such as healthcare providers, administrators, board members, but also through simply persevering and showing hospital personnel the benefits of physical activity in their own patients. And as you can see from the quote on this slide here, this expert highlights how opinions have been changing in their institution because the hospital staff themselves are seeing the improvement in their patients. Our experts also described how caregivers were important allies and gatekeepers to lasting behavior change. So engaging caregivers in the development or delivery of the in-hospital physical activity programs and using targeted educational strategies to show caregivers the benefits of physical activity for their child was described as important for ensuring children would have access to or would be able to take part in the in-hospital physical activity. And then with regards to programming features, experts were very clear about the importance of making it fun while also tailoring to each patient's unique needs. So when developing in-hospital physical activity, ensuring that enjoyment was at the forefront by including less structured and more flexible physical activity programming was important. So really these experts conveyed to us that they recognized they were working with children and adolescents, and in order to keep them engaged, fun had to be prioritized. And then in terms of tailoring, experts considered things like age, so both biological age, but also the developmental status of the child, their medical status and treatment effects, so how they were doing medically, any physical restrictions, either from cancer and its treatment itself or from existing conditions, as well as the child or adolescent's goals and preferences when planning out each in-hospital physical activity session. And I'd be happy to describe each of these considerations in a bit more detail and how our experts consider them and use them within their programs during the Q&A if anyone's interested. And then last, what we learned was that very similar processes for in-hospital physical activity were taking place across sites. Particularly, the physical activity specialist would check in with the healthcare team to see if the timing was okay and to check on the status of the child or adolescent. From there, depending on the response, they might then proceed down the yes side to speak with the patient and caregiver. And in that case, depending on the patient and caregiver's response, they would either have an in-hospital physical activity session, they would come back and check in again later, or they would have no physical activity. So if the patient wasn't feeling up to it or they had guests or somebody visiting, and in that case, when there was no physical activity, they would always leave indicating they'd come back another day. Coming back to the beginning, again, when they checked in with healthcare provider, if the response was later, they would just come back later in the day, a few hours, sometimes an hour, depending on how close they were to their hospital. And then they'd either proceed down the yes pathway or the no pathway. And if it was no, it was often because it was not a good day. So either the child was in treatment all day, they were having really adverse symptoms or side effects. And so in that case, the physical activity specialist would leave a message with the patient and caregiver and once more come back another day. So you'll see that across sites, this process always restarted with the healthcare team check-in and proceeded from there. At this point, I also want to highlight that across interviews, a common or uniting thread that tied the themes together, and even this process map that came out of it, was the sentiment of patience. So taking time developing relationships and in-hospital physical activity opportunities, taking time implementing it, being willing and able to refine it, and being patient as norms and downstream shifts occurred. Taking time to foster and establish relationships with patients and their caregivers, including families in the process, and particularly being patient and flexible within their own schedule, knowing that the in-hospital physical activity might not always occur on their timeline, depending on the status of the patient. So right now, we're currently speaking to our local healthcare providers and staff at the children's hospitals in Alberta, so the Stollery Children's Hospital and the Alberta Children's Hospital, to understand their barriers and facilitators to in-hospital physical activity, and to determine if and how the recommendations, processes, and strategies identified by our international experts will need to change to meet their needs. So the results from this component will enable us to outline in-hospital physical activity based on guidance from those who have been successful and taking into account our local context. From there, we'll speak with children and adolescents affected by cancer and their caregivers. And we felt that speaking with this group last was important so that we could set expectations appropriately, so we would already know the systems and the confines within which we were working, and we could create something that not only fits our context, but also this, the stakeholder group's needs. And currently our research ethics is under review for this project. And so then after we gather information from all three stakeholder groups, we'll then return what we come up with as the in-hospital physical activity planning to each group to get further input and feedback. And we'll continue modifying and refining as needed before we move on to implementation and evaluation. And at this point, because we are still a little ways away from actual implementation, we're planning on tracking things like fidelity and acceptability of implementation and exploring the impact of in-hospital physical activity on this population's health-related outcomes. But I should state that the specific outcomes for our evaluation plan are also going to be co-created by our stakeholders. And then we continue to amend and modify our in-hospital physical activity implementation and evaluation plans throughout, because we really feel that the ongoing monitoring and evaluation and flexibility will be critical for this translation project. So those still at the early stages, the outputs from this project are allowing us to incorporate stakeholders' voices, which will enable us to better understand in-hospital physical activity in Alberta, and then what we need to do to ensure successful implementation and sustainability so we can eventually scale up and share this model with other sites who can modify it to fit their context. So in closing, I would like to acknowledge the lab where I'm doing my postdoctoral work, particularly my supervisor, Dr. Nicole Koulos-Reed, the incredible students who are working on this project, the stakeholders that we've had the opportunity to work with who are sharing their insights and their time so selflessly, and our collaborators, particularly Kelly, who I've listed here, who's a knowledge translation implementation scientist at Alberta Health Services, and of course the SPORE Evidence Alliance for funding this work. And so I'd just like to thank everyone here also for your time, and I'll now take any questions that anybody might have.
Thanks, Amanda. So we have about 7 or 8 minutes for questions here. I can get the ball rolling. So something I was wondering was, how has COVID impacted the development of this?
Yeah, so that's a very interesting question. And it was interesting the timing at which we were collecting some of this data too, because our international experts, for example, are integrated within the hospital system. So they continued seeing patients throughout, whereas we are currently outside of the hospital system. So for our community programs, we've pivoted like many others, and we're offering community programs online right now. But with this, we've started to think outside the box a little bit. So a lot of the questions and a lot of the things that are coming out in our interviews right now with local healthcare providers is how we could continue offering in-hospital physical activity if and when something like this happens again. So we started to think about potentially having, I'm using air quotes, but I guess nobody can see me, remotely delivered in-hospital physical activity where a child would be paired with a physical activity specialist and they could receive their session online. Because until we're kind of part of the standard treatment, things like COVID will kind of continue to impact our ability to seamlessly offer these types of opportunities.
Interesting, thank you. Another question I have here is, what engagement strategies are you using for this project?
Yeah, so we're doing, I suppose, like more simple things like respecting people's time, ensuring clear and consistent communication. So by providing updates on the project, because as I'm sure many on the call know, oftentimes research takes a little longer than we expect, and then all of a sudden it's moving much quicker than we expect. So we've been providing as many updates as we can along the way. We're also being really respectful of the changed climate we're in, particularly the extra burden on our local stakeholders, so the healthcare providers here. And then we're also really approaching this by viewing participants from a research ethics stance as true partners. So we see our stakeholders, the healthcare providers we're speaking with now, they're giving us information that we just don't have access to. And so we're really viewing them as partners in this research. And that includes checking our own biases and ideas for what physical activity opportunities might be at the door. And then we're also using process mapping procedures. So we're allowing them to map out for us how and when physical activity would work within their current care.
Perfect. Thank you. Well, I don't see any questions coming in at the moment, so let's move on to Lisa Nisley's presentation. So thank you so much, Amanda, for your presentation. And then if anyone has a question that they think of, maybe we'll have time at the end for that. So thank you very much.